In this video, we will be covering cardiac dysarrhythmias. Before learning the dysarrhythmias, you must know about cardiac conduction system and ECG. You can go through my previous videos for both conduction system and ECG. The link is in the description. What is dysarrhythmias? Dysarrhythmias are disorders of the formation or conduction of the electrical impulse within the heart. These disorders can cause disturbances of the heart rate, the heart rhythm, or both. Dysarrhythmias may initially be known by the hemodynamic effect they cause. For example, a change in conduction may change the pumping action of the heart and cause decreased blood pressure. Dysarrhythmias may be detected by change in pulse, abnormality on auscultation of heart rate, or diagnosed by analyzing the ECG waveform to see ECG abnormality. Continuous cardiac monitoring is indicated for potentially life-threatening dysarrhythmias. Their treatment is based on the frequency and severity of symptoms produced. Dysarrhythmias are named according to the site of origin of the electrical impulse and the mechanism of formation or conduction involved. For example, an impulse that originates in the sinoatrial node and at a slow rate is called sinus bradycardia. Any disorder of the heartbeat is called a dysarrhythmia. Although the terms arrhythmia and dysarrhythmia are often used interchangeably, dysarrhythmia is more accurate. Dysarrhythmias may arise from the SA node or anywhere within the atria or ventricles. Dysarrhythmia which arises from the SA node is called sinus bradycardia or tachycardia. Dysarrhythmias which arise from anywhere within the atria or ventricle are known as ectopy or ectopic beats. Some dysarrhythmias may be benign, that means it is not harmful, and asymptomatic means no symptoms present, whereas other dysarrhythmias are life-threatening. Although many dysarrhythmias have no signs and symptoms, others have serious consequences if not treated. Now let us see normal electrical conduction. The electrical impulse that stimulates and paces the cardiac muscle normally originates in the SA node, also called the sinus node. In the adult, the electrical impulse usually occurs at the rate of 60 to 100 times a minute. The electrical impulse quickly travels from the SA node through the atria to the AV node. This process is known as conduction. The electrical stimulation of the muscle cells of the atria causes them to contract. The structure of the AV node slows the electrical impulse, giving the atria time to contract and fill the ventricles with blood. This part of atrial contraction is frequently referred to as the atrial kick and accounts for nearly 1/3 of the volume ejected during ventricular contraction. The electrical impulse then travels very quickly through the bundle of keys to the right and left bundle branches and the Purkinje fibers located in the ventricular muscle. The electrical stimulation is called depolarization and the mechanical contraction is called systole. Electrical relaxation is called repolarization and the mechanical relaxation is called diastole. The process from sinus node electrical impulse generation through ventricular repolarization completes the electromechanical circuit and the cycle begins again. Now let us see influences on heart rate and contractility. The heart rate is influenced by the autonomic nervous system, which consists of sympathetic and parasympathetic fibers. Sympathetic nerve fibers, also referred to as adrenergic fibers, are attached to the heart and arteries as well as several other areas in the body. Stimulation of the sympathetic system increases heart rate, that is positive chronotropy. Conduction through the AV node, that is positive dromotropy, and the force of myocardial contraction, that is positive ionotropy. Sympathetic stimulation also constricts peripheral blood vessels, therefore increasing blood pressure. Parasympathetic nerve fibers are also attached to the heart and arteries. Parasympathetic stimulation reduces the heart rate, that is negative chronotropy, reduces AV conduction, that is negative dromotropy, and the force of atrial myocardial contraction. The decreased sympathetic stimulation results in dilation of arteries, thereby lowering blood pressure. Manipulation of the autonomic nervous system may increase or decrease the incidence of dysarrhythmias. Increased sympathetic stimulation, for example, caused by exercise, anxiety, fever, or administration of catecholamines such as dopamine, aminophylline, or dobutamine may increase the incidence of dysarrhythmias. Decreased sympathetic stimulation, for example, with rest and state reduction methods such as therapeutic communication or meditation or administration of beta-adrenergic blocking agents may decrease the incidence of dysarrhythmias. Now let us see what is normal sinus rhythm. Electrical conduction that begins in the SA node generates a sinus rhythm. Normal sinus rhythm occurs when the electrical impulse starts at a regular rate and rhythm in the SA node and travels through the normal conduction pathway. Normal sinus rhythm has the following characteristics. Ventricular and atrial rate will be 60 to 100 beats per minute in the adult. Ventricular and atrial rhythm will be regular. QRS shape and duration will be usually normal but may be regularly abnormal. P wave is normal and consistent in shape, always in front of the QRS. PR interval, consistent interval between 0.12 and 0.20 seconds. P is to QRS ratio will be 1:1. Although normal sinus rhythm is generally indicative of good cardiovascular health, patients with an average resting heart rate that exceeds 90 beats per minute over a 24-hour period should receive a full medical workup for potential underlying causes. Now let us see types of dysarrhythmias. Dysarrhythmias include sinus dysarrhythmias, atrial dysarrhythmias, junctional dysarrhythmias, ventricular dysarrhythmias, conduction abnormalities. First, let us see sinus node dysarrhythmias. Sinus node dysarrhythmias originate in the SA node. These include sinus bradycardia, sinus tachycardia, and sinus arrhythmia. First, we will see sinus bradycardia. Sinus bradycardia occurs when the SA node creates an impulse at a slower than normal rate. The causes of sinus bradycardia are altered metabolic states such as hypothyroidism, lower metabolic needs, for example, sleep, athletic training. The process of aging which causes increasing fibrotic tissue and scarring of SA node. Certain cardiac diseases such as acute MI, especially inferior wall MI. Vagal stimulation, for example, from omitting, suctioning, severe pain. Medications such as calcium channel blockage, for example, nifedipine, amiodarone, and beta blockage, for example, metoprolol. Idiopathic sinus node dysfunction, increased intracranial pressure, coronary artery disease, unstable and symptomatic bradycardia is frequently due to hypoxemia. Other possible causes include acute altered mental status, for example, delirium, and acute decompensated heart failure. Slow heart rate may be due to sinus node dysfunction, previously known as sick sinus syndrome, which has a number of risk factors including increased age, weight raise, obesity, hypertension, lower heart rate, and history of cardiovascular event such as myocardial infarction, heart failure, or stroke. Tachycardia syndrome is a term used when bradycardia alternates with tachycardia. All characteristics of sinus bradycardia are the same as those of normal sinus rhythm except for the rate. The rate will be less than 60 beats per minute in the adult. The clinical significance of sinus bradycardia depends on how the patient tolerates it. Manifestations of symptomatic bradycardia include pale, cool skin. The patient may have hypotension, weakness. Patient will be having angina, dizziness, confusion, and shortness of breath. Now let us see the management. The patient is assessed to determine the hemodynamic effect and the possible cause of the dysarrhythmia. If the decrease in heart rate results from stimulation of the vagus nerve, such as with bearing down during defecation or omitting, the attempts to be made to prevent further vagal stimulation. If the bradycardia is caused by a medication such as beta blocker, the medication may be withheld. If the slow heart rate causes significant hemodynamic changes resulting in shortness of breath, acute alteration of mental status, angina, hypotension, ST segment changes, or premature ventricular complexes, treatment is directed toward increasing the heart rate. In such patients, we have to increase the heart rate. Management depends on the cause and symptoms. Resolving the causative factors may be the only treatment needed. If the bradycardia produces signs and symptoms of clinically instability, for example, acute alteration in mental status, chest discomfort, or hypotension, 0.5 mg of atropine may be given rapidly as an IV bolus and repeated every 3 to 5 minutes until a maximum dose of 3 mg is given. Atropine 0.5 mg IV push blocks vagal stimulation to the SA node and therefore accelerates heart rate. Rarely, if the bradycardia is unresponsive to atropine, emergency transcutaneous pacing can be instituted or catecholamines such as dopamine or epinephrine are given. Dopamine and epinephrine are alternatives if atropine is ineffective. If bradycardia persists, a pacemaker may be required. Sinus bradycardia is common in athletic individuals and does not require any treatment. Now let us see sinus tachycardia. Sinus tachycardia occurs when the sinus node creates an impulse at a faster than normal rate. Sympathetic nerve fibers, which act to speed up excitation of the SA node, are stimulated by underlying causes such as anxiety, exercise, fever, shock, drugs, altered metabolic states such as hyperthyroidism, or electrolyte disturbances. The wave of impulse is transmitted through the normal conduction pathways. The rate of sinus stimulation is simply greater than normal, that is, more than 100 beats per minute. The causes of tachycardia: physiologic or psychological stress. For example, acute blood loss because of anemia, shock, hyperolemia, hypovolemia, heart failure, pain, hypermetabolic states, fever, exercise, anxiety. Medications that stimulate the sympathetic response, for example, catecholamines, aminophylline, atropine. Then stimulants, for example, caffeine, nicotine, and illicit drugs, for example, amphetamines, cocaine, ecstasy. Enhanced automaticity of the SA node or excessive sympathetic tone with a reduced parasympathetic tone that is out of proportion to physiologic demands, a condition called inappropriate sinus tachycardia. These have no proportion to physiologic demands. Autonomic dysfunction, which results in a type of sinus tachycardia referred to as postural orthostatic tachycardia syndrome, that is POTS. POTS is characterized by tachycardia, increase in heart rate greater than 30 beats per minute without hypertension when moving to a standing position, or with frequent symptoms such as palpitations, lightheadedness, weakness, and blurred vision that occur with standing. All aspects of sinus tachycardia are the same as those of normal sinus rhythm, except for the rate. The ventricular and radial rate will be greater than 100 beats per minute in the adult, but usually less than 120 beats per minute. Sinus tachycardia does not start or end suddenly. That is, it is known as non-paroxysmal. As the heart rate increases, the diastolic filling time decreases, possibly resulting in reduced cardiac output and subsequent symptoms of syncope and low blood pressure. If the rapid rate persists and the heart cannot compensate for the decreased ventricular filling, the patient may develop acute pulmonary edema. The clinical significance of sinus tachycardia depends on the patient's tolerance of the increased heart rate. The patient may have dizziness, dyspnea, and hypotension because of decreased carbon dioxide. An increased heart rate increases myocardial oxygen consumption. Because of the increased oxygen in the blood, the carbon dioxide will be decreased. Angina or an increase in infarction size may occur with the sinus tachycardia in those with coronary artery disease or an acute MI. Now let us see medical management. The treatment is directed toward elimination of the cause rather than the dysrhythmia. Sometimes this is a compensatory mechanism for decreased cardiac output, thus correction is not needed. Urgency is dependent on the effect of rapid heart rate on coronary artery filling time to prevent cardiac ischemia. Medical management of sinus tachycardia is determined by the severity of symptoms and is directed at identifying and abolishing its cause. Administration of oxygen and normal saline solution should be considered as initial treatment. If the tachycardia is persistent and causing hemodynamic instability, synchronized cardioversion is the treatment of choice. Otherwise, vagal maneuvers such as carotid sinus massage, gagging, bearing down against a closed glottis as if having a bowel movement, forceful and sustained cuffing, and applied a cold stimulus to the face such as immersing the face in ice water or administration of adenosine may be considered to interrupt the tachycardia. These increase parasympathetic stimulation, causing slower conduction through the AV node and blocking the re-entry of the rerouted impulse. Beta blockers such as class 2 antiarrhythmic and calcium channel blockers, that is class 4 antiarrhythmic, or the rarely used, may also be considered in a narrow QRS tachycardia. If the tachycardia has a wide QRS, then adenosine is considered only if the QRS is monomorphic, that is uniform shape, and the ventricular rhythm is regular. Otherwise, procainamide, amiodarone, and sotalol are the options in the wide QRS tachycardia. Catheter ablation of the SN node may be used in cases of persistent inappropriate sinus tachycardia unresponsive to other treatment. Treatment for POTS often involves a combination of approaches with treatment targeted at the underlying problem. For example, patients with hypovolemia may be advised to increase their fluid and sodium intake or use salt tablets if necessary. Now let us see sinus arrhythmia. Sinus arrhythmia occurs when the sinus node creates an impulse at an irregular rhythm. It results from changes in intrathoracic pressure during breathing. In this context, the term arrhythmia does not mean an absence of rhythm, as the term suggests. Instead, the heart rate increases slightly during inspiration and decreases slightly during exhalation. This irregular rhythm is frequently observed in healthy adults. Non-respiratory causes include heart disease and valvular disease, but these are rare. Sinus arrhythmias are occasionally due to non-respiratory causes such as digoxin or morphine. These drugs enhance vagal tone and cause decreased heart rate and irregularity unrelated to the respiratory cycle. Sinus arrhythmia has all the characteristics of normal sinus rhythm except for its irregularity. The PP and RR intervals vary, with the difference between the shortest and the longest intervals being greater than 0.12 seconds. That is 3 small blocks. Sinus arrhythmia does not cause any significant hemodynamic effect, and therefore it is not typically treated.